So, hello everybody. Welcome to this series of Educations of Health podcast in support of World Heart Day. My name is Preeti Minhas and I'm the Assistant Director of Clinical Learning at Education for Health. And today I'm delighted to be joined once again by our guest speakers today, Louise Clayton, who is the co-chair of the Alliance of Heart Failure, and Jim Moore, who is a GP, sits on the steering committee of the Alliance of Heart Failure. So before we delve into the summary of today's podcast, if I could ask you both to introduce yourselves again to our audience, that would be great.
Hi, yes, I'm Louise Clayton, and I'm the co-chair of the Alliance for Heart Failure. I'm also a heart failure advanced clinical practitioner based in Leicestershire.
And I am Jim Moore. I'm a GP. I'm also a GP GP with a special interest working for the Gloucestershire Heart Failure Service. And as you said, Preeti, I'm also on the steering council of the Alliance for Heart Failure.
Thank you both for joining us once again. So as we said, today forms part of one of two podcasts. The first podcast you would have heard, we discussed around the burden of heart failure. And today we'll be discussing a summary around the brief classifications of heart failure. We'll be exploring the 4 pillars of treatment, and we'll also be looking at how multidisciplinary teams really play a pivotal role in delivering quality outcomes for patients with heart failure. So I'll hand it over to both of you to take it over for today.
Thanks very much, Preeti. And so podcast 2 really follows hopefully nicely on from where we ended in podcast 1. There was some discussion in podcast 1 around diagnosis and the importance of a timely referral of someone with suspected heart failure. And that referral will go to our local cardiology teams in secondary care, or it could go to a community heart failure service. So there is no specific pathway across the country that this follows. In an ideal world, that referral, though, would be triaged by a heart failure specialist. The next step in the pathway is making a diagnosis and undertaking an appropriate investigation. And in almost all cases where someone is referred with suspected heart failure, they will have an echocardiogram, an ultrasound of the heart, which gives us information about the structure of the heart. It tells us about the heart valves. It also tells us about the overall function. Is the heart effectively working as a pump? And on the basis of what we find within that echocardiogram, that will guide further management. A proportion, of course, of echocardiograms that we undertake will turn out to be normal, and that person who's been referred with breathlessness or other symptoms may have another reason for that. So it's worth, I think, just spending a little time on the classification of heart failure and what we might discover on our echocardiograms. And the most up-to-date classification gives us 3 different categories of heart failure. And this is based around something called ejection fraction. So during the heart cycle, when the left ventricle is filling, that's part of the cycle called diastole. At the end of diastole, you have a certain amount of blood within the left ventricle. And then when the heart contracts, that systolic contraction, and empties, we would expect that ventricle to shift at least 50% of the blood that's been sitting in the ventricle at the end of diastole. We call that the ejection fraction. And the classification for heart failure is based around ejection fraction. We have 3 different categories. Heart failure with reduced ejection fraction, that's where there's a reduction in the ejection fraction down to 40% or below. And that's the area of heart failure where we have most evidence. That's where the evidence-based drugs that many of you will be familiar with that are used in heart failure have their evidence. The category heart failure with mildly reduced ejection fraction, and although this is an area that we've always known about, where the ejection fraction sits between 40 and 49%. It's an area where we don't have as much evidence. But the evidence that we do have suggests to us that in the majority of cases, people with heart failure with mildly reduced ejection fraction are probably early cases of heart failure with reduced ejection fraction. So over a period of time, that ejection fraction will drop and they become people with heart failure with reduced ejection fraction. The third category is where the ejection fraction is actually normal, so it's 50% or above. But the abnormality in function of the heart is in the filling, in the relaxation of the left ventricle. So the left ventricle becomes stiff, and as a consequence, it doesn't fill with as much blood that can then be ejected out and into the circulation. For heart failure with preserved ejection fraction, again, we have up till recently had, we haven't really had evidence-based treatments, but along with heart failure with mildly reduced ejection fraction and with heart failure with preserved ejection fraction, we now have evidence of benefit of the group of drugs called SGLT2 inhibitors. So moving on to treatment, I think and management, I think the best place to start is probably where we have most evidence, Louise, and that's with heart failure with reduced ejection fraction and the pillars, the so-called pillars of treatment.
Absolutely. And as you say, Jim, it's been an interesting last decade, hasn't it? We started off with many of these drugs way back 20 years ago, if not 30 years ago, for those of us that have been practicing in heart failure for that long. And, you know, when we look back at the evidence base over all these years, we started off with the RASI therapy, with the ACE inhibitors, ARBs, and then the beta blockers. And actually, they are still within those four pillars. So the RASI therapy and beta blockers still hanging on in there. And actually, the evidence base is extremely strong. So we're talking about the prils, ramipril, commonly used in most areas still. And we talk about lisinopril, beta blockers. We're talking about bisoprolol and carvedilol, again, the commonly used ones. And these are ones that people will be very used to using for heart failure patients with that reduced ejection fraction that you talked about. It gets a lot more complicated, doesn't it, when we're talking about the HFmrEF and the HFpEF patients. But certainly, as you say, that evidence base for the four pillars is absolutely what we should all be aiming for. And if we sort of jump forward to the last decade, adding into that RASI therapy group, then we've got the ARNIs, and only one in the class, obviously, Entresto. So if we're looking at getting these drugs on board for these patients, it's not just about, as you well know, getting the drugs on. It's about monitoring them, making sure that the patients have access to the drugs, and that, you know, in a lot of cases where we've got specialists either helping or actually providing the care to make sure that these drugs are monitored appropriately. So we've talked about four pillars a lot, that's two. So the other ones, of course, mineralocorticoids, very important, spironolactone and eplerenone, and the SGLT2 inhibitors, which you've mentioned a couple of times, being the latest ones to add the four pillars. Diuretics, I think, cannot go unmentioned. Absolutely the most important drug for symptom relief, of course, in most of our heart failure patients. The majority of them do not get away without having diuretics. And of course, to make them feel better, which is what most of our patients actually want and value, they do need to have their diuretics at the appropriate doses. I think some of the challenge comes not just about looking at guidelines and not just about knowing which drugs to give to patients. The order which to give them can be quite challenging. And when we look at some of the complexities around getting these drugs on board and up to good doses, as a heart failure specialist nurse, obviously I've been doing this for a very long time, and the current 4 pillars can potentially require 10 to 12 titrations to get the patients onto the right drugs. Now, historically, of course, we did this very slowly, very carefully, and spent an awful lot of time doing this. I think what we now all understand and appreciate is that actually these drugs can be provided for patients much quicker than we previously thought. And actually that is completely the right thing to do. So maybe the approach to the scheduling or the ordering of the drugs isn't necessarily the most important, but making sure that the patients have access to all 4 pillars in the appropriate time frame, i.e. as quickly as possible, is actually the sort of the focus of where we're at. So I think with that in mind, as a GP and working obviously in primary care, I know how long this takes me as a specialist to help and support. What would your thoughts be on how we can sort of manage that from a primary care point of view? You've got very short, limited times to see patients in a clinic, for example. So how can we sort of go about this as a joint working kind of approach?
And that's a great question, because if we want to, Louise, deliver effective healthcare to our heart failure patients, it's going to need that an integrated, multidisciplinary team approach. That was a beautiful summary of the pillars and description of where we've been in terms of introducing therapies and where we are now. And I think it's really important to share with our audience, Louise, that classical approach, the ACE or ARBs and then the beta blockers and one added to another, optimized, is not our approach now. We've got good evidence that the sooner we get those medicines on board, starting with small doses, getting all the pillars on board if they're tolerated, and then starting to titrate is really, really important. But of course, that adds complexity. Choice of drugs for heart failure patients adds complexity, and that makes it very difficult, I think, for generalists within primary care to make these choices. You and I, Louise, spend a lot of time seeing people with heart failure, and for us it becomes intuitive, the choice of drugs, but it's more difficult, I think, for our generalist colleagues. That is where being in, we're having patients involved with heart failure specialist teams, and the jewel in the crown, or jewels in the crown as I describe them, heart failure specialist nurses, are really, really important to oversee treatment. So importantly, a management plan, but also ideally some oversight from heart failure specialists. And I'm going to reiterate that a heart failure specialist could be a cardiologist, a GPSI, could be a heart failure specialist nurse, and probably increasingly in the future could be a clinical pharmacist. So the role of primary care, so I've described the challenges, and we know we have the evidence that tells us that where primary care is given the major responsibility of optimization, it's a real challenge. But I think that landscape is beginning to change. There's some really interesting work being done with they're not now that new healthcare professional group, because they've been with us and doing sterling work for a long time in primary care, but clinical pharmacists. And there are some training programs which have gone on around the country to educate, upskill clinical pharmacists to support the work of heart failure teams in terms of optimizing our patients with heart failure. So, I mean, in my head, that sort of structure has the oversight of the specialist team, but where we are asking clinical pharmacists within practices to help with the titrations, just to monitor them with that oversight. And there are some good examples where that is working really, really well.
And I think the important person to remember in what you just said there, of course, is the patient. So the key to this, I find, is from the outset, making sure that the patient is absolutely engaged, is completely aware of what their treatment pathway or their journey may look like. And actually, the years have gone by now where we used to sort of say we can stabilise your condition and hopefully make you feel a little bit better. We don't talk like that to patients now. We can actually improve things, and this is where the evidence base has taken us now. So I think if patients are aware of that from the outset, with whichever healthcare professional is seeing them, and is involved in that planning process of getting all the right drugs on quickly, being very much a partner in ensuring that those drugs and treatments are in place, I think things tend to move a lot smoother. And of course, we've got lots of other new opportunities now, haven't we? And I know locally you've been certainly tapping into some of these. We've got some of the virtual approaches with things like heart failure at home, and telephone consultations, of course, during COVID became an absolute must. And it still does actually surprise me how many titrations and how many consultations we managed to achieve during COVID over the telephone. Titrations did not stop in my region, and I know they didn't stop in your region. We continued to get drugs out to patients, and we managed a lot of the titrations with the patient support over the telephone. And that's not high tech, that's very simple. So I think, like you say, it's engaging the wider workforce, making sure that the patients are fully engaged, and then looking at other opportunities, isn't it? I mean, I know you did quite a lot of work on the virtual consultation process. So what are your thoughts about that now?
So I just want to emphasise that important point about patient empowerment. Louise, it's such a good, but because it's such a good point, because we sometimes lose sight of the patient being at the centre of this, and I think we develop more effective pathways if we remember our patient and what we're actually trying to achieve. And you briefly mentioned there some of the national initiatives managing heart failure at home. What's central to managing heart failure at home? It's patient education. It's patients having a set of scales to watch their weight, having a blood pressure machine that will record not only their blood pressure and their pulse. And during COVID, as you quite rightly said, these were the things that allowed us to do that virtual consultation more easily. And I think particularly our heart failure specialist nurses became very skilled at virtual consultations, telephone triage, being able to answer, to ask the right questions, ask the patient, take the patient's recordings of their weight, etc., and to give them a picture where I think they have increasingly become comfortable around managing. I think if we think pre-COVID, Louise, and we said, well, we can do an awful lot of this virtually, and rather than having to see people face to face, I think many of us would put our hands up and say, not convinced by that. So yeah. I think that landscape absolutely has changed, but patients are integral to that. And we talk about traffic light systems, red, amber, and green system, where you have symptoms which are really important in your red group, and then there are green symptoms in your green group where you are reassured in terms of follow-up, etc. So virtual consultations are now very much a part of heart failure, an important part of heart failure management. And emphasize the point, all patients should have a set of scales, have some education around their condition, so they know that if they're getting more breathless, their ankles are swelling, not only can we share with them ideas around altering their diuretics themselves, but also when they need to seek advice, particularly if they need to seek advice urgently.
Absolutely. And I think, essentially it's that we've all got, or what we should all be striving for is, it's almost like a sort of a bucket of options, isn't it? And one size doesn't fit all for each region. and each area needs to understand, I think, where they're at, what's your baseline, what's available, and then use that to the best of our abilities. So, you know, different areas will have different setups for monitoring, different access to levels of workforce. And it's about having that sort of that package that works best in your region. And as I say, it's not going to be the same for everybody. But I think we would certainly agree and would certainly encourage across all of the regions would be the absolute necessity, I would say. It's not a wish list, it's a necessity for a primary and secondary care specialist integrated multidisciplinary team in some guise or other. And, you know, certainly my thoughts on this is GPs, practice nurses, those clinical pharmacists that you talked about, engaging with the specialist team, probably through a virtual MDT, just because it's more efficient use of our time, and having that opportunity to discuss patients, having that opportunity to have that sort of peer education, peer support, talking about the complexities of heart failure, because we know it's a complex condition to treat. And actually that sort of multidisciplinary team, I think, is absolutely the way to go. And we're not there yet, that's for sure, in each region, but I know you have a very good setup. So I'm sure you'll be a complete advocate for that. So what would your thoughts be on the integration?
Absolutely. And I, you know, Louise, I often wondered about how we could get primary care engaged with our MDTs because of just simply the timing. How do you find that a particular GP of that particular patient to be engaged with the process? But firstly, if you've got a GP as part of your MDT, it could be a GPSI, but just having the primary care perspective, I think, is helpful. But I've seen some really interesting work going on in different areas where GPs now book appointments into an MDT setting. So, you know, it's known that in an area on a particular morning at a particular time, the heart failure specialist team will meet. And GPs can actually book themselves in patients into a specific time slot. And the areas that has that's currently being piloted, it's working superbly well. So again, that extends the MDT. You know, Louise, that we've already extended our MDTs beyond our heart failure specialist team. We have our renal physicians, and at times we'll have our elderly care patients who are looking after the elderly involved. We might have a palliative care specialist involved in those discussions. Just thinking, lastly, you know, we're getting to the end of the second podcast, and thinking about are there any other areas that are important, particularly from a primary care perspective? I'm just going to mention the monitoring role of primary care. So, again, you're very much aware that primary care is incentivized to actually review heart failure patients on an annual basis, and this is through QOF, the Qualities and Outcomes Framework. In fact, the NICE guidelines tells us that we should be reviewing our heart failure patients twice a year, but I think once a year is a good start. And so for me, that was the move whereby a heart failure in primary care became a long-term condition. And for me, the obvious way to actually deliver that annual monitoring is in a long-term condition clinic, and that's happening in many areas across the country. And one of the other interesting initiatives around this is because we've got so many cardiology and non-cardiology long-term conditions clinics that typically our nurses are delivering in primary care. And because within those long-term conditions clinics, we typically do very similar things. So we will be checking blood pressure and weight and pulse, whether someone, presents with established vascular disease, or whether we're looking at them from the point of view of hypertension, whether we're looking at them with heart failure or diabetes. So we're doing similar things, and it struck many of us that we should be doing multiple long-term conditions assessment at one sitting, and it would make it much more efficient. And again, there's some exciting work being done around the country where, a patient comes along to a clinic and may have their diabetes, their established vascular disease, the coronary artery disease, their heart failure, all reviewed at the one sitting. And it makes it much, much more efficient way of working. But those monitoring, those annual reviews are really important, because they will increasingly be the point at which we can look and see whether all the evidence-based therapies have been considered in patients with heart failure. It will present opportunities for us or for the team in primary care to optimize those therapies if that hasn't happened. Importantly, it's also an opportunity just to, of course, ask about symptoms. And it may be that if patients have early symptoms of decompensation, then we can quickly refer them back to the heart failure specialist team for review. So I think monitoring long-term condition clinics will become increasingly important in primary care.
I think you've absolutely hit the nail on the head. That's where this integration becomes key, doesn't it? It's the pathway and the flow for the patients. They're not sitting in one place. They don't need to see 10 different people about their one condition. What they need is somebody who is going to be their key person, but that person has got the support of others, bringing in their speciality, their ideas. And when, the patients become less well, or they're struggling with certain symptoms, as you say, the healthcare professional that's looking after them can just seek advice from that integrated MDT, rather than having to wait for another outpatient appointment, or the patient's got to go somewhere else. And that integration across the workforce has got to be the right thing, hasn't it?
Absolutely. And, summing up the podcast, that's probably the most important thing that we can share with our audience today. Well, two things really. One is about the importance of patient education, but the other is about multidisciplinary team into working and integrated care, and the undoubted benefits of that approach in supporting people with heart failure.
Great. Well, thank you so much, Louise and Jim, for taking time out of your busy schedules to give us two podcasts, which have got really valuable information in there around some practical tips around what we can do differently, whether that's as individuals or as teams, and things that we can implement locally and across our areas, or even at a regional level. So we really do hope you've enjoyed this series of podcasts to support World Heart Day. And these podcasts have provided you both with the knowledge and know-how to support patients in this arena. Remember, it's not just you as an individual, it's you as a team. It's about providing consistent healthcare to our patients, irrespective of the team members that they see today. So it's really about putting person-centered approach at the core of what we do. If you'd like further information around our courses or other resources that can support you, please visit www.educationforhealth.org. Thank you for listening to us, and thank you to our guest speakers once again.